Okay, how do you want to start this? What are we talking about today, or do you just want to go in as a continuation?
I think we'll start with what we're talking about today, because actually what we were meant to be talking about last time, we kind of started on, and then it became a bit too big, so we segmented. But I think, given the number of messages and questions that we get every week around recovery from injury or kind of living with long-term conditions, it would be good to talk about pain and coping strategies and that sort of thing. I think there's that. What we wanted to talk about last week was about that recovery isn't about getting your old body back. It's about building a new relationship with the one that you have now and working at ways to move forward and build your capabilities from your starting point that you're currently in. Does that make sense?
Yeah, I think that is a good place. So if we're gonna try to constrain the conversation, we'll talk about pain, I guess ideas of recovery and expectations. I think that's pretty good. So should we go for
Yeah.
that?
Yeah.
All right.
I think let's do, as a starting point, we've been talking a lot about what is pain and different types of pain. So let's start with
Yeah.
what is pain? And
Okay.
we often talk
Well,
about the three types of
let's
pain.
all right. Let's go for that. So same thing we talked about in the last podcast is pain is complex. And pain is not always a one-to-one relationship between damage or threat or mechanical issues and the sensation of pain. And our basic idea around pain has really become much more nuanced over the last few decades. It's there's a lot of people studying it. There's a lot of people studying it from different angles, and generally, I think we're moving in a direction that's a bit more empowering than the way that we used to talk about pain 20 or 30 years ago. So there's a bunch of just different research organizations. And I'll just pull a definition from the IASP, which is the International Association for the Study of Pain. And they say pain is an unpleasant sensory emotional experience associated with or resembling that associated with actual or potential tissue damage. So that's kind of an academic thing. So they're saying either is or it resembles um, this sensation that you get that could be correlated with tissue damage, but may not be. So that's kind of complicated. I'll probably reference Greg Lemon a lot today, and he's someone I'd like to get on the podcast in the future. One of the things he always really tries to push is this idea that pain is an output of the nervous system. He'll sometimes use this analogy of an alarm. So let's say you have an alarm system in your house and the alarm starts going off. You don't always know what it is. You know, is it carbon monoxide? Is it a smoke detector? Is a door open? Is there an electrical fault? Sometimes we just have these alarms and it's just the system saying, hey, something is wrong. I'm trying to draw your attention to it. But that doesn't mean you can figure out exactly what is wrong because this alarm is going off. Sometimes people use heart attacks as an example. So you could be having a heart attack, and the heart attack is a result of something being wrong with your heart, whether it's your heart is dying, you're not getting blood flow, there's some electrical issue with your heart. And the way that people feel heart attacks, cardiac arrest can be all different ways. Some people feel it as pain in their jaw. Some people feel it as a radiating pain down the left side of their body. Some people feel it as chest pain. Some people sometimes think it's bad case of gas. Sometimes people feel it as back pain. So even though you could be having the same problem, the way your body is communicating that issue with you isn't always clear. We always have issues with referred pain as well. What I mean is sometimes someone can have an injury, maybe in their internal shoulder structure, and the way where they feel that pain is somewhere down their humor. So it's imprecise. So it's now put in the nervous system, and generally it reflects some sort of perceived threat, or your body saying, "Hey, watch out, something is going on." But it's not always calibrated precisely. And you were talking about those three kinds of pain.
I think it's quite useful to know that there are different types of pain, and that you might move through,
Yeah.
different versions of pain.
So what most people, when they think of as pain, the model that most people have pain is often what's called nociceptive pain. And this is the kind of pain that's common with acute pain where there's tissue damage. So you tear a muscle, you sprain an ankle, and you feel pain. And that generally has this direct one-to-one overlap with some kind of injury. But even that changes too. You know, when you first get injured, As someone who's been in a few car accidents and scooter and motorcycle accidents, you don't always feel that pain right away. Your body can sometimes be in shock, and you'll think you're not that badly injured, and then you try to do something, or the pain will suddenly hit you like an hour later or something like that. Also, post surgery is a good example. The pain can come in waves. So you've got your nociceptive pain, which is this acute pain associated with tissue damage. Then you have your neuropathic pain, and this is actually pain that's associated with some sort of injury or disease or inflammation of the nervous system. So think things like sciatica, often that sort of burning, hard to describe pain that's associated with some kind of nerve damage in the lower back. Or another one we see is what's called diabetic neuropathy, and that is for people who've had diabetes, untreated diabetes, or advanced diabetes over long term. Aspects of their nervous system can start to degrade, and that can cause all kinds of very hard to define pain, and also issues with sensation and things like that. And then the last kind of pain, which I think is the one that is so confusing and can be conflated with other kinds of pain, and they can overlap. It's never just one. Often it is different kinds of pain in conversation with each other. Is this nociplastic pain, and this is pain that arises from often no clear one-to-one relationship between tissue damage. A lot of times, what we call chronic pain, and sometimes this can be, or it's often caused through this sort of amplification or this over sensitivity of your nociceptors, and these are the tools in your body that perceive pain, or another way of putting it is that they perceive potential threats and they translate that into pain. So this is kind of, you can have an overly sensitive alarm system. You think of a car alarm where somebody walks by it and it's always going off. That could be an example of nociplastic pain where it's overly sensitive. It can go off all the time, sometimes for unclear reasons. Another example is if you set up motion sensor lights and they're too sensitive, you'll have your lights go off in the middle of the night over and over and over again. Doesn't mean anything's happened. It just sort of means that for whatever reason, the sensitivity is cranked up and it could be firing all the time. So the issue comes is sometimes because people conflate these and they know what it feels like when they have that nociceptive pain, that specific tissue damage. Sometimes that means that they're dealing with more chronic or issues that are harder to define or issues that they've had over a long period of time. Sometimes our sensation of pain might not even be tied to a specific mechanistic or tissue injury. Sometimes it's just our nervous system sort of being miscalibrated or overly sensitive.
Yeah. And then I think what we talk about a lot is the sort of, I guess that's the next bit, isn't it? It's the sort of maybe the slight tension or conflict between this kind of biopsychosocial model of how the body works within our environment and how, it's a complex system of systems, and that more rigid, can I say, slightly older model of biomechanics that is possibly a little reductionist in the way that it looks
Yeah,
at how
yeah,
injury works and how recovery works. Is that fair to say? I don't want. I'm keen to say that one is not. I think there are good elements of both. I'm trying
yeah.
to sort
I
of.
think when we talk about these complex issues, I think it's good to apply different lenses, and different lenses and different modalities are different tools for different jobs, which are also going to be limited based on the tools that you're using or the system that you're a part of. So you're going to look at pain differently if you're in an orthopedic clinic or you're an orthopedic surgeon, or if you're a biomechanist than if, say, whatever, you're a massage therapist or you're a physio. People are going to apply all different kinds of lenses. Um, and with all these, all these people are going to have different levels of nuance and complexity in the way they look at it. So if we say, well, a biomechanist might look at it this way, there probably are some old school biomechanists who look at this one-to-one relationship between injury and pain. And then obviously there's going to be a lot of more progressive people. So anything we say, we're not trying to disparage any one group of people. It's like I said in the previous podcast. I've met some great chiropractors. I've met some very iffy chiropractors. I met some great physios. I've met some terrible physios. So it's not necessarily the profession. It's sort of what people do with that. So that being said, there is this tension between what's sometimes called the kinesiopathological model, or this sort of, as you said, kind of reductionist one-to-one model. And this is kind of the idea that you feel pain because there is something wrong with your body. There's a misalignment. Maybe you're doing something wrong, or there's something that if we did a scan, it would show up on a scan. There's some kind of mechanistic or physical cause for that pain. So the classic example we talked about last time is if someone's experiencing back pain, the idea is you can give them a back scan. You say, this is what's causing your pain, even though it's often much more complex. And one of the issues with applying or overly applying this model is you do kind of create this fragile narrative about how our bodies work. Instead of our bodies being these complex systems that can adapt, which we'll talk about in a second, it's this idea. Sometimes you'll hear people talk about this assumption that your body is like a Jenga tower. So imagine a Jenga tower of, all these sort of precarious bricks, and they're organized just right. And if someone pulls the wrong brick out, the whole tower is going to collapse. And that's not really how it works. If we look at dynamical systems theories and all these ideas of complexity, what we realize is actually our body is very robust. It's very resilient. Some people might use the term anti-fragile. But we sort of have this dexterity, or this word sometimes degeneracy, which is that there's all different kinds of ways to get the job done. Just because you have an injury or something's happened to you doesn't mean you'll never be able to do a task again or do that task without pain. So an example, when I tore my tendon, so I ruptured my tendon, my distal bicep tendon, and I was still able to do everything that you need to do with your bicep. I was still able to eat. I could pick up things. I could rotate my wrist, my forearm. I could do all these things, enough so that it was hard to diagnose at first, because a lot of people are like, no, you still have full function. And it was very hard for me to explain to them, no, I can tell that's not. But because your body has so many overlapping systems, if you do have an issue, you're going to find a solution. So if you lack ankle dorsiflexion, which I do because of another old injury, I can still run. Maybe the way I run doesn't look like other people, but I can still get from A to B, and I can still sprint if I need to. Or, another example, if you have limited hip flexion, or if you have limited knee flexion, or if you have limited internal rotation at your hip or something like that, you can still do something that looks like a squat. You can get the job done. Someone might come and say, oh, that's not optimal, or it's causing pain. So the reason I'm saying all this is because there's so many different ways for your body to do things. We're actually very good at self-organizing, and often the form or the solutions that people come up with on their own are very clever solutions that work for them. But a real strict biomechanist might come in and say, oh no, what you're doing isn't optimal, and we can tell what you're doing isn't optimal because when you run, your hips abduct too much. Or when you try to get your arm overhead, what we can actually see is that you're compensating in your scapula or something like that. And if you have this idea of something being optimal, then you can tell people that what they're doing is wrong. And that's quite tricky because that can be a really disempowering narrative. A lot of times people will go into a practitioner, and depending on the personality of the practitioner, where they come from and what modality they're working, they can say, oh, you're doing this wrong, you're doing that wrong, you're running wrong, you're breathing wrong, you're walking wrong, you're sitting wrong, you're standing wrong. And actually none of those value judgments have any basis in reality. A lot of times just biases that people have, and they say, oh, well, it should look like this. And I think we can probably talk about posture and things later. So anyway, so you have this
I think those
kinesiopathological model. Go ahead.
those narratives, though, they start from a really young age. I remember going to a Pilates class in my 20s, and it was really terrifying because I kept doing everything wrong because I'd never done it before. It was the only Pilates class I've ever been to. But I do think, this is not a knock on all Pilates, but I think there is, as with a lot of movement disciplines, they can be very dogmatic. And if you're that way inclined, then it can be a very extreme version of this thing. So Pilates often, I think the more extreme end does tend to fall into that kind of narrative of this is, they talk often about alignment, and we'll go into this in another episode, but this idea of alignment therefore kind of means that there is the concept of something that is not aligned correctly. And therefore, if you're a cautious person and you're worried about pain and movement, telling someone that they've got bad alignment and that their alignment needs to get better, it just kind of starts this fear cycle that we talked about previously, on that kind of fear avoidance cycle. And then you just believe that you're doing everything wrong and that you don't know how to get this perfect alignment, which is, to me, feels really limiting. And then there's this whole thing around power dynamics, but I think that is probably for another episode because I've got some thoughts on it. But anyway, back to
Well, I want to say something about that, and we'll talk about it in a later episode as well. But the sort of the perverse issue there is as well is that, like, if you're doing something wrong, if you're doing something wrong with scare quotes, it means that the other person can show you the right way to do it. You know, so they're like, no, you're standing wrong, you're breathing wrong. Come to me, and I'll tell you how to do it right. And yeah, we'll talk about it later. But the issue with that is people want to be told that there is one simple, correct answer that will fix everything. And there's always going to be someone who pops up and says, hey, I'm here to solve all your problems. But that's just, that is objectively wrong, I would say. And, you know, as you were saying, the problem with all these reductive sort of optimized models of there's a wrong way and right way to do things, like you said, it creates this nocebo effect, which just gets people afraid to do everything, which is so disempowering. And I think it really goes against that sort of first tenet, you know, of being a practitioner, which is first do no harm. If you're going to open up with this narrative where everyone's doing stuff wrong and they're fragile and they're weak and their bodies are decayed or whatever, then you've automatically done harm with your very first opening interaction with somebody.
yeah, and then you can go on social media and sell that message because it's so concise and so easy.
Yeah.
And then you can create your own little method. Anyway, that's another episode about guru dynamics and
Oh yeah. So
methods.
we were talking about the kinesiopathological model, and I guess you wanted to talk
Yes,
about
we
the
were.
biopsychosocial model. Okay. Okay.
I
So
think it's good I think it's good to talk about the biopsychosocial model because I think it will resonate with a lot of people, and it is so much more. It just feels like a lot of common sense, and I think when you look at the kind of how we live and how our bodies are within our social context and our environments, and so I think it's to me it resonates much more than the
yeah,
more reductive model.
and you know, it tends, as with most things, you know, the answer is somewhere in the middle. And what I like about the biopsychosocial model is it's like, well, the answer is somewhere in the middle. And I want to clarify one of the things that biopsychosocial model isn't. It's not saying that everything is all in your head. A lot of times people hear it and they say, "Oh, so you're saying my pain isn't real?" It's like, no, 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 no. It's, you know, the clue is in the name. It's biopsychosocial, which is to say that you know, there's going to be a biological component, and that is real. There is going to be a psychological component, and that is real. And there's going to be both interacting with each other. And there's also going to be socially how people think about pain and beliefs about pain and recovery and injury. You know, people's perception of pain is going to be very different if they, you know, if they have like a Western model or a traditional Chinese model. And, you know, the way that they tackle pain is going to be different. And you know, the funny thing with the placebo effect is lots of different models seem to work. So you could have, you know, people who practice 5 or 6 different methodologies, and they can all help with the pain. You know, and if they're radically different theories, but they all seem to work, does it mean that they're all right? Well, you kind of have to have a model that includes the possibility that they are all right, which means that there is going to be a psychological and social component. So the biopsychosocial model is saying, it's like, look, if you experience pain, you know, there's going to be that biological, that maybe there's tissue damage or there's some kind of mechanical issue with your back or something like that. So there's that. It's going to be your own internal perception of that pain and your beliefs about that pain. And it's going to be what people tell you. So again, it does mean that pain is going to correlate imperfectly with the state of your tissues. What I mean is, you know, there may or may not be some physical reason why you're feeling that pain. And it's also going to be influenced by all kinds of contexts. You know, we know this is true. Pain is going to be influenced by sleep, by your stress, by your mood, by your sense of uncertainty. Sometimes just giving people an answer can help, or anything that can build up a sense of agency is so important. What are your prior experiences with pain? You know, what are your beliefs? What are your expectations? and it can be so different. And that's why people who do experience chronic pain, or you said it really well the other day. It's like by the time you hit your 40s, you're going to accumulate a certain amount of injuries. You're going to have a certain amount of pain, and it's sort of dishonest to create that expectation that people should be pain free. So I'm 42 now. I have a whole number of injuries, and I've had a couple surgeries and things like that. In the morning when I wake up, sometimes I'm stiff, and I start moving. And, some days I do have a bit of back pain. It doesn't stop me from doing the things that I want to do because I feel like I have a plan and I feel like I have some agency. And I feel like if I do certain things, it can help control that pain. And that's okay. I still get to do everything I want to do. I get to play pickleball. I get to go hiking. I get to work out and lift heavy weights. But it is about that constant conversation with your body.
I just like that you got your pickleball mention in there. Andrew has recently
Yeah.
injured himself playing pickleball against a group of 70-year-olds,
I didn't injure myself on a
which
7-year-old. I injured myself on a wall trying to impress some 7-year-olds by doing like a dive into the back corner to save, and I forgot a wall was there, so I crashed into it. But I'm about 8 weeks in now, and I've probably recovered from one of the most brutal pickleball injuries in the history of the sport, I'd like to think.
I think everyone was pretty shocked by the level of impact that how your body met the wall.
I mean, I would like to
Um,
think that if any of my pickleball partners had an injury like that, then they probably would have been severely injured. I would like to think that because I have a young, strong 40-year-old body, that's really what saved me.
there you go. Just wait for another 20 years and you will be captain of the pickleball team. Sorry, we got a little bit. I just enjoy talking about pickleball. I think it would be good. I'm mindful of the time and that we're trying to keep this under 30 minutes. I think it would be good to talk about long-term progress with pain or after injury and how we can expand our capabilities. Because I do think something that's come up a lot recently because we've got a new Strong for Life cohort coming in. There are a lot of questions around their, individuals' limitations. Obviously, like you said, once you're over 40, everyone's got some kind of injury or limitation, and our bodies don't move as they used to, which is fine and normal. But I think it's useful to have some rules of thumb that you can kind of go to when things feel particularly bad. And it might not be that you're in acute pain right now, but maybe you've got an injury and it's frustrating you that you can't do the things that you used to be able
Mm.
to do. And so I think giving people a few rules of thumb. I'm just thinking about when you did your back as well. There were just a
Yeah.
few rules of thumb that were very, very helpful to kind of know this too shall pass. And I'm just looking at our notes and we've written calm things down
Mm.
and then build things up.
Yeah. Well, all
So
right.
let's go into that as a
Sure.
finisher.
So I'll talk about the two lever model in a second, which is this kind of idea that if you are working around an injury, there's really, you sort of have two goals or two duties: calm things down, so reduce that hypersensitivity and build things up. I guess the background on that would be one of the things you want to remember is that your tissues are adaptable. We say this all the time, but your bones and muscles, they're not these inert, dead things. They're these living systems that can adapt. And the way that they adapt and get better is by giving them the right kind of stimulus, by giving them the right amount of nourishment. So your body, you can work with your body, say, okay, this is important to me. I want to continue doing this, or I want to improve that. So there is this concept of expose to protect. And this expose to protect model is the sort of thing you can't cover yourself in bubble wrap, because the less exposure you give yourself to different stimuli, it means that when you are exposed to those stimuli, there's a good chance your body's going to freak out and your nervous system isn't going to know what to do. So if you try to expose yourself to a broad, variable, I don't know, I'm going to say buffet of different movements and different stimuli, you're going to build up the mechanical strength and capabilities, whether through bone density, muscle density, ligament, tendons, things like that. But you're always checking in with your nervous system, say, hey, this is okay. I want to do this. In the past, when I was talking with Todd Hargrove, he was talking about this idea of regaining territory. When you have an injury, it's like someone erased the map to your body. And what you want to do is you almost have to think of yourself as an explorer. You have to go back out there and sort of redraw the map so you can see what's going on. And the recommendation, this is always don't do too much too soon, but you do want to explore and kind of add in different things over time. So when we talk about things like this, remember it's over the long term. But with this two lever model, the first thing you want to do is you want to calm things down. And, I can use my own back as an example because I had a pretty classic lower back pain incident where one of the biggest issues is my body, like the alarms are just going off and going womp, 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 womp. And you become hypersensitive to things that wouldn't normally set you off. And again, it's not because necessarily you're recausing tissue damage or even because you have tissue damage. It could be almost completely based on your nervous system, but it means little things that wouldn't normally freak your body out start freaking out. So if you just hit a certain angle when you're trying to bend something over, your body will freak out and it will send this sort of pulsing absolute pain through your body. That's not because you've done damage. That's because your nervous system hasn't recalibrated itself. So, at first you do want to do, I'm not going to use the word guarding because sometimes people can apply that for too long, but you do want to temporarily reduce the volume, the intensity, the speed, the range of motion, the frequency, whatever. You want to give your body a chance to go back to like homeostasis. It's okay to add some extra variability, in exercise terms. If you're a runner and you start to feel pain, certain thing, there's nothing wrong with changing your tempo, or your range of motion, or your technique to work around it. You don't want to punish your body. You don't want to say, oh, this isn't real, so I'll just ignore it. It's not about ignoring it. It's giving your body the chance to calm down. You want to improve your recovery by making sure you get good rest, sleep, maybe bring the pacing down. You just kind of want to imagine there's like a knob, almost like you're getting feedback on a sound system. You just want to turn that down a little bit. Very much like if a microphone is too close to a speaker and you get that feedback, just turn that down a little bit, and your body can relax. Narrative is going to be really important here as well. You want to do what's called de-threatening the narrative. Specifically, you're trying not to catastrophize, and this is where you have this idea of this too shall pass. Your body is adaptable. You want to have that sort of growth mindset and say, okay, look, I'm in a lot of pain right now. This isn't going to be forever, and the way I'm going to claw back, out of this pain hole is going to be, just climbing out of it, sort of one brick at a time, re-exploring. Don't catastrophize. Just because you've had an injury doesn't mean that's it. The way you're feeling right now isn't the way you're going to feel forever, and you want to have that conversation with your body. The other thing that's important is working with someone who gives you options, or if you're working by yourself, giving yourself options. Provide yourself some kind of game plan. You want to feel like you can do something. You want to feel like you have the tools to get better, because you do. And it's in constant flux. You're not going to regain the body that you had when you were 20, but that's okay, because you are gonna find a sort of happy medium that works for you. So just having a sense of autonomy or agency can reduce the threat, and that's what we're trying to do when we're talking about this nervous system pain, is reduce that sense of threat. And the other thing that I think is really important is you want to avoid falling into a guru hole or a savior hole. What I mean is, you really don't want to develop a relationship with one practitioner who says that they are going to fix you. You really want to find someone who says that they are going to build up a relationship between you, them, and your body. And I don't mean that in a naughty way. I just mean that in like a way, like you want to develop a relationship with someone so that over time, you can all work together to rebuild your body and regain your capabilities. So that's the big one. And I guess the other person I want to draw attention to is Peter O'Sullivan, who's very good on this. And he has helped develop what's called cognitive functional therapy. And this is really used all around the world. The NHS has picked it up. And it's this idea of sense making. So giving patients, giving people a sense of what their pain is. And then they follow a similar path, which is this idea of exposure with control. So you do want to have this exposure, whatever that issue, that position, that movement is, that for some reason causes that sort of defensive reaction. You want to start layering it back into your life, and then finding ways that you get that right dosage so you can work with it. So this idea of exposure with control, a graded return to whatever the feared or avoided activities are. Because you don't want to put yourself in this cage of super protective movements or fear of movement all the time. You really want to make sure that as soon as things have calmed down, you can start trying to live a normal life again and start getting back to a goal activity. And that's really important as well. I think one of the things that's so important about having hobbies or sports or things that you like to do is they give you a goal to go back to. So if you say, you know what, I want to make sure that I can continue to hike, or I want to continue I want to make sure I can continue to garden. Having those goal activities is really important because it gives you a guiding light. And then one of the last aspects of this
I think
CFT.
there's
Oh,
there's just one
can I say the last one?
the way that Neil. Yeah, well, I'm just going to add in because it links that Neil
Hmm.
Teasner talks a lot about that sort of flirting with pain to sort of find
Yeah,
out,
that's a very good example.
you know, I do think that's a really nice way of thinking about it, is kind of flirting on the edges of it, because not all pain is bad. Especially when when you did your back in, you kind of have to come up to that edge of pain. Right? Okay, this is tolerable. I can do this. I can move through this bit. And then slowly over time, you kind of regain that range of motion. But it took a really long time, and you did have to sort of reprogram your body to accept that and to kind of just push through a little bit on that edge of that difference between what pain is manageable and when it's not.
Yeah, this idea of having a conversation with your body. I think Jarlo Alano, he kind of uses this analogy of a rusty hinge, so a hinge in a door that's rusted. And at first, you put in some oil or lubrication or whatever, that can be the movement. And at first, it doesn't move at all, but then you can just kind of wiggle it back and forth just a few degrees. And then over time, just the process of moving the hinge back and forth eventually will unlock it. If you try to do it all at once, then you're likely to snap the metal. But if you add a little bit of lubrication, a little bit of oil, and you wiggle it back and forth, a little bit of oil back and forth, over time, you can get a hinge that was completely rusted, and you can open it back up again. And it's that same sort of pattern.
I'm just mindful of time, so let's start wrapping up. Did you want to finish
Yeah.
on
Well,
your building up?
well, I mean that's a big part of it. A lot of what I was saying already. I mean, I guess in terms if we're thinking about rehab, if you talk to a practitioner, one of the things that always gets me, whether it's physio or whatever, is people will say, "Well, I want you to do this program." Rehab is sort of only useful if people will actually do it. So giving people a list of exercises that aren't meaningful to them isn't going to work because they have to do it. It also has to, a little bit of discomfort is okay. So for example, when I had my tendon reattached, I was doing a lot of very small movements, and I started doing it a little bit earlier than I was supposed to because I kind of felt like I was tolerating it well. But I would just put my hand on the table, and I would just use my other hand to kind of move it back and forth a little bit. And the first few days, that's all I had, and then I was able to push it back and forth a little bit more, and that was within tolerable pain. You want to make sure that you give people things that they can tolerate. It shouldn't be, you don't want people to suffer. And it's really important to align the rehab or the movements with people's goals. Again, it can't be something that feels like it's foisted upon them. People have to have a clear idea of what they want to do and why they want to do it. You want to make sure that you have some kind of clear plan for progression, whether that's like a progressive overload, adding more weight, more range of motion, adding a little bit of more chaos or variability into it. And people should feel like when they're doing this that they are getting some kind of improvement in confidence and function over time. The biggest thing that is really a part of what we try to do, and I think what a lot of good practitioners do, regardless of the background, is you want to create that sense of agency, not dependency. And you don't want to, sometimes people will pretend they have the specificity that they just don't have. They'll say, you have to do exactly this way or else it won't work. That's just going to lead to catastrophizing again. If you're working with someone, they say, well, it doesn't feel good when I do it this way, but if I do it this way, it feels okay. Yeah, that's probably okay. It's probably fine as long as you're working towards something. But I guess the biggest takeaway, if you are someone who's experiencing pain right now, is just going back to that dual lever model. Calm it down. So if you're experiencing lots of pain right now, calm it down. Don't try to power through it if it's intense pain. Give yourself a couple days of rest and just do little things and kind of explore, flirt with that pain. And then once you feel like you've gotten past that like alarm zone, where you're hypervigilant, then what you want to do is you want to start building things back up again. So you want to start exposing yourself to the movements that in the past have caused pain, but you want to do it in such a way that even though there's a little bit of discomfort, you feel like you're making progress in some way. And I think as long as you have that as a model, and you don't need to worry about things being perfect or optimal, but you just kind of want to have a goal you're working towards, I think that's going to be a much more useful mindset than trying to find some guru who's going to give you the one perfect movement that's going to cure all your problems.
Which leads us nicely on to the next episode, which I think will be on gurus and the problem with this idea of doing it wrong. Anything else to add on pain before we finish? Like not bogged down in or not trapped in that narrative of absolutes. So in that I can't do this because it will set off this. Sometimes that can be true. Like not all movement's going to be a good fit for you, but sometimes we can get trapped in a narrative of this is. I think particularly with back pain, you can think this is the movement that caused my back pain, therefore I will avoid that movement. And often, especially with back pain, it's rarely the one movement that you were last doing when you did. It's a sort of combination of things.
Yeah, context is so important,
helpful?
and I think so. And just because something hurt you on one day, I mean, something caused a sensation of pain doesn't mean it's going to do it every day. And without getting too woo-woo into it, one of the things I really can't overemphasize is how much stress and rest and things like that can affect back pain. So we have someone in our lives who had horrible sciatica and back pain, and they were trying to do all these different things. They were seeing these different therapists, all these different things. And then what happened is they sort of semi-retired, sold their company, and they were just less stressed out. And almost immediately, all that back pain that had been with them for years more or less disappeared. I'm sure it flares up from time to time. I don't want to say that they never experience it again, but it was like night and day, and they can do all these things that they love. They just couldn't do because they were in this hypervigilant, chronic stress state. And that is just literally, it's going to turn up that volume knob on your nociceptors. Yeah. The last thing I would say is just that there are, we've got some other good podcasts on this, so you can help me with this. We got the Tom Morrison one. We've got the one with Joanne.
Joanna Myers.
And yeah, so Joanna Myers, and then we've
And I
got
think
the
that
one
the
with
Charlo one as well. I'll link
Jarlo, yeah,
to them in the show notes.
and then the Todd Hargrove one as well.
Todd Hargrove, as ever. All right, I think we've done well. We're at 37 minutes, so nearly 30. Right, we'll see you next time.